organisms here. In this is the margin, air, water margin, this is a drop there. So these motile organisms you can see here. So this is the same thing, but it's a liquid interface. Motile organisms can be seen. So motility of microbes we use as identification feature. Usually E. coli is motile, Klebsiella is non-motile. True motility organisms move in different directions and change their position in the field. As you drift in, it's not a proper motility. Brownian movements are there. Any oscillatory movement about a nearly fixed point. Those are not considered as motility. Once we have identified, we do antimicrobial susceptibility testing, and it came as susceptible to meropenem, cotrimazole, and methicillin, synacid, and resistant to cefotaxone, cefotaxime, coamoxiclav, and ciprofloxacin. So it indicates multi-drug resistant variety because it is almost resistant to up to third generation cephalosporin and also beta-lactamase combination. So it indicates probable extended spectrum beta-lactamase producer. But we won't, if there is a test in laboratory we can do while approximating ceftriaxone, this with coamoxiclav, ceftriaxone containing ceftriaxone disc alone or ceftriaxone with clavulanic acid, but it's not in new level we are expecting. We can observe or appreciate keyhole appearance. But in here, based on this resistance, what we have to know it, what is ESB, extended spectrum beta lactamase. So then, according to by definition, we can't use up to third generation cephalosporins. If it is sensitive to piperacillin tazobactam or ticarcillin clavulanic like beta lactamase inhibitor combinations we can treat, but by definition we often tell ESBL we treat with carbapenem like meropenem. So this is ESBL isolate. What is the preferred treatment? Either imipenem or meropenem. Duration of treatment not due to ESBL, it is patient is having urine tract infection, not pyelonephritis. Blood culture also negative, and also clinical features suggestive of low urine tract infection rather. So we can give minimum 5 days. We can monitor the response with CRP values in 48 hours time, and also we can do repeat urine culture at day 5 to assess the urine clearance. And same time we can offer, if patient is responding, we can discharge patient in 2 or 3 days while giving methicillin or synacid for completion of 5 days, like total antibiotic duration including the initial meropenem. Or otherwise, depending on susceptibility, we can give aminoglycoside, but it's IV form. Oral form only available to treat this ESBL is methicillin. There are no oral carbapenems available in Sri Lanka like biapenem. So if it is resistant, if it is susceptible to ciprofloxacin, we can treat. But in this case, if it's resistant, my idea is to highlight about methicillin. You have to know this when you are doing your final appointments as well as become house officers. So that's how we treat the case related to. Now I think aim is to why we are doing this laboratory testing. So this practical implies group of bacteria called Enterobacteriaceae. So there are peculiar features like I said earlier. They are oxidase negative, converts nitrates into nitrites, as well as they are glucose fermenters. So that is Enterobacteriaceae. Other group is, if it is oxidase positive, that is gram-negative bacilli. It is more towards Pseudomonas or Burkholderia species. So once we have differentiated using phenotypic characteristics, their colony appearance, grand stain property almost same. Their colony appearance, but colony appearance is a not strong one. We go with biochemical characteristics like growing them in Macuncaca, clade agar, and even KIA. We check their ability of using the ability of differentiation. We use lactose fermenting ability, weak or non-lactose fermenting ability, and also we use motility test if required. We do the differentiation of these organisms. That's what we are expecting is practical. KI interpretation is very much important. So other organisms like Proteus species, what I said, it is a motile one. Once we put them in a blood agar plate in center and incubated on next day, we can see multiple waves on around. It's termed swarming motility. It's another one. Okay. If you do a motility testing using peptone growth and agin test, what I showed, you can see nice motility. And also if in KIA it is slant acidic, but sorry, alkaline, but is acidic, but it's produce hydrogen sulfide, H2S, not a gas producer. So you can see peritrichous flagellas are there, so it involves to movement. And it is not a non-lactose ferment. That's why it appears as this slant is alkaline. So Proteus species which cause urinary infection as well as Proteus that is mirabilis, but also it causes wound infection as well. Other enterobacterial species, non-lactose fermenter, Salmonella and Shigella, discussed as a separate practical. And about Citrobacter, Enterobacter, they are emerging microbes. They are associated with polymicrobial resistance and associated with hospital-acquired infection. So it's not much discussion, but just to see what is K pattern. Often both strong lactose fermenters. Here, Providentia and Morganella also, just to know it, we are not expecting much. Can see non-lactose fermenter. So here, for the sake of interest, there's a case report here. I just put, you can see if you are interested. You can read later on. This is one of my presentation. You can see the abstract. It's mainly caused by spondylodystitis, that is infection in vertebral column, mainly vertebrae infection. You can see the case presentation. So the CT, MRI, thoracic area, you can see how this is the area we are disrupted. Following Enterobacter agglomerans infection, you can see CT thorax, how it has decayed. Okay, it's almost gone. Like you can see further. This regeneration, now it's completely recovered. So discussion, just read. You can see this article. Thank you. About that. So in summary, you have to know what is corresponding number 1. Deamination of amino acid. Number 2, yes. Here number 2. This is the control. 1, 2, 3, 4, 5. That's what you have to know. Here it is 1, I said it's pseudomonas, non-entering. Here weak lactose fermenters, non-lactose fermenter. Here they are strong lactose fermenter, but later turn into they are. But Citrobacter, there are different varieties. You just keep mind it's H2S producer. E. coli, Enterobacter, and Klebsiella are there. Okay. Some E. coli are there which produce H2S, but in new level we are expecting this. So bit of microbial identification methods. We said phenotypic, can classify genotypic and antigen detection and proteomics. So phenotypic, you know, there are rapid methods, there are analytical product index, API and RAPID. And automated platforms are there like Vitek2, BD Phoenix. Once we are putting culture from the disk into that particular cassette and we are putting into machine, within 4 hours like we can get the identity as well as ABS. But RAPID and those things we are semi-automated. you're just doing the biochemical test in same plate, but we want to read by us. Genotopically, we know PCR, nucleic acid amplification test there. Nowadays, PCR, COVID-19, it's related, and film marriage. That's a multiple PCR platforms are there in same one. Antigen detection, again, due to this COVID-19, now we are going to detect antigens. Lateral flow immunochromatography test we can use as uh, rapid identification method. So point of care test like, and proteomics, we use mold it off using proteomics characteristic for the identification. Thank you.